Good evening. I'm Charla Jackson, president of the Camellia Rose, Georgia chapter of the Links Incorporated. Thank you so much for joining us for the second part of our series on breast cancer. And tonight you are going to learn everything that you need to know about breast cancer and how it impacts Black women. And moderating our discussion tonight is Lolita Jackson. She is the past president of Camellia Rose. And she currently serves as the Director of Policy and Intergovernmental Affairs at the City of Atlanta Department of Watershed Management. She has worked in corporate America, Georgia Power, Comcast, and she has been listed as on the list of 100 women of 100 of Georgia's most influential women. We are so proud and so happy to bring you Lolita Jackson. Thank you.
Thank you, Charla. And so we're going to get started today with Dr. Spencer. And let me introduce Dr. Spencer to you. She is a surgeon, and it's Dr. April Spencer. I apologize here. Let me find her bio, and I will share it with you.
Just let the audience know I'm a board certified general surgeon, and I did my fellowship training at MD Anderson Cancer Center. And I was born in Chicago, but raised here in Atlanta. And I started private practice almost 20 years ago. And it's Dr. Spencer's Global Breast Health and Wellness Center, where I focus on 100% breast services to men, women, and adolescents. And it's always a pleasure to take.
Thank you, Dr. Spencer. I apologize for that. Let me just say that she completed a general surgery resident at her residency at Grady Memorial Hospital and was awarded the Susan G. Komen sponsored breast surgery fellowship and MD Anderson Cancer Center. She's an active member of Leadership Atlanta, the best class ever, class of 2019. And she recently launched her your cosmetic line. So congratulations to that. Tailor-made cosmetics. It is safe, simple, and a sexy option for healthy, environmentally conscious consumers. Welcome, Dr. Spencer.
Oh, thank you so much for having me, Lolita. It's only a pleasure.
Okay. And so, we're talking about breast health today.
Yeah.
I really appreciate you taking the time to join us and look forward to sharing your expertise with our audience and friends. So let's start with detection and prevention. And so the first question with that is, how is breast cancer detected?
Usually breast cancer is detected a number of ways. Oftentimes the individual will feel the lump themselves, or their partner may feel the lump. That's why it's so important to be aware of your breasts. If you see something, say something. So the first line of defense is the individual. You have to be diligent in making sure you are aware of what your breasts look like, what they feel like, and not just the breasts themselves, Alita, but also the underarm. Also be aware of any changes in the skin, because there are certain breast cancers that only present in the skin. And oftentimes when women are asked to do their monthly breast exam, they usually think about feeling for or looking for what? Lumps. But there are other things that can be a sign of breast cancer other than a lump. The other way in which we detect breast cancer is through mammography. And so that's extremely important that women get their annual mammograms, because it allows us to see things before they become apparent, before you can even feel them. Lolita, usually it takes a lump about a centimeter or so, or it's been growing sometimes for a year or more before a woman is even able to detect it themselves. And that's why screening mammograms are so important. Now, a lot of people ask me, like, what's the difference between a screening mammogram and a diagnostic mammogram? So the screening mammogram is the absence of symptoms. Means you don't feel anything, you don't see anything. This is your annual mammogram that you're having done without any current concern. So that's how it's detected.
Okay. And so With annual mammograms, and you're talking about going annually, and sometimes individuals are sent back for additional screenings. This actually happened to me twice over the past 10 years or so, and it's pretty scary.
It is.
And I was told that I had my tissue was dense, but all turned out well. What are there different types of mammograms? Is kind of a two-part question here. Are there different types of mammograms? And if so, is there something that women should talk to their doctors about or request a certain type of screening or testing method?
Sure. So that's an excellent question. So the two
Mhm.
main types is your diagnostic and your screening. As I mentioned before, screening is the absence of symptoms, and then diagnostic is when there's some additional views required because there's been a change from the last mammogram to the next. Or there's a scenario where a woman may have had a mammogram, their first screening mammogram, and they don't really know if what they're seeing has been there prior to. So oftentimes they will get a call back. The bottom line, ladies and the men that are watching, if you get a call
Yeah.
back, go back. It's not always a breast cancer, but it allows us to have a better view and take some additional imaging and to compare it to imaging in the past to see, hey, is this new or is this just an overlap of breast tissue? Is this something real? In terms of the specific type, right now, 3D mammography has become very popular. Most places you don't have to request it. It's the standard in many imaging centers. If you are in a small community-based location, you may want to request a 3D mammogram or go to a facility that offers 3D mammograms. Why is that something that's important? Because sometimes the 3D mammogram will allow us as clinicians and the radiologists who will be looking at the films to be able to see it more clearly when there's some dense breast tissue. Does this mean that our standard mammograms that we've been using for over 30 years is substandard and you can't diagnose breast cancer? No, it does not mean that. But the 3D is oftentimes more helpful for women with dense breast tissue. Density is just when the thickness of the tissue is more more significant, so that the entire breast hardly has any fat in it at all, but just more so a lot of structure. So lumps can sometimes hide or be obscured, and
Okay.
that's why 3D mammograms are so important.
So can a person ask for that specifically?
Yes, they
Yeah.
can.
Okay.
Not
Okay. So
always.
that's good to know. I didn't know that.
Yeah. And the thing is, Olita, the great thing is that with a lot of community support, many of the
Mhm.
facilities have been able to do fundraising or put it in the capital budget to have 3D mammography at the center. So a lot of women aren't having to ask for it, it's readily available.
Oh,
So
that's
if you're
wonderful.
anywhere it may not be available, I think it's important to ask. And if they don't have it, you can always Google or find out where the nearest facility is that offers 3D mammography in your neighborhood or near your place of work.
Okay. So we heard from Dr. Contessa Metcalf last night, and she discussed as her motto, prevention is the key to healthy living. In
Mhm.
addition to mammograms and being educated around are there other preventative measures uh, for preventing breast cancer? I mean, one of the questions in particular I receive is including diet. How much of what we eat could play a role in breast health?
Sure. And I'll address the diet last because it's a very common question, a very important one. I usually
Mhm.
like to make things simple and I call it the ABCs of breast cancer prevention. So the A is awareness. Be aware of the guidelines. The guidelines are screening mammograms starting at age 40. And so if you have a family history, you may want to get it 5 to 10 years before
Okay, that
the age of 40. Awareness of your body. If you see something, say something. The B is behavior. There are things that you can do to lower your risk, such as exercise. There's lots of data, lots of research that show that an elevated BMI or body mass index and obesity can increase our risk of not only getting breast cancer, but also increase our risk of recurrence and also can impact the quality of life of the individual. The other B in terms of behavior is just being mindful of what you're eating. You know, every time we sit down to eat, we're either feeding or fighting disease. So I always like to present the data so that women can know that what we're doing is not based on opinion or how we feel, but facts. So
Mhm.
what current research show is that there's no one magic diet, no one magic thing that you can eat to prevent breast cancer. But we do know from research that foods that are high in saturated fat should be limited. We should try to limit our intake of sugars, processed foods. And I like to encourage my patients, instead of taking foods away, I encourage them to add more food. So add more fresh fruits and vegetables, particularly
Mhm.
the cruciferous vegetables. And those are like your broccolis, your cauliflower, etc. There's lots of data to support adding healthy items to our culinary choices. And then lastly is C in terms of prevention, and that is consumer choices. There's so many environmental toxins that are out there that we're putting in our bodies, not just with food, but on our bodies. And so just be mindful that when you are getting your cosmetics products or your sunscreens and your lotions, your perfumes, that you're reading the labels, even our shampoos and relaxers. We've got to be more vigilant in our community in making sure that we are looking for carcinogens. And people may say, well, how do you know if it's a carcinogen? Usually, a lot of the packaging now will say paraben free or phthalate free. These are like the buzzwords that you'll see on the packaging. So just make sure that it is a brand that is mindful of having the carcinogens to be eliminated from the consumer product.
Thank you so much. That is very helpful. And I've been eating cauliflower lately, so that helps me feel really
That does
good.
help you.
I am going to now, I understand Dr. Phillips Reed is joining us for this discussion. And so thank you so much for joining us, Dr. Phillips Reed. We are glad to have you. And I'll say a brief introduction. Dr. Phillips Reed is I'm sorry. She saw the need for programs that would increase the public knowledge and awareness of breast cancer to reduce the mortality and morbidity of the disease. And in 1989, she founded Sisters by Choice, which is initially formed as a support group for women diagnosed with breast cancer and their families. Sisters by Choice, and I've participated in your annual walk. Has evolved into a multifaceted organization serving women in Georgia. Dr. Phillips Reed is also a surgeon. And so welcome to our conversation on breast health.
It is indeed a pleasure to be here. And I'd like to say hi to Dr. Speed. I haven't seen her in a while, but thank you for inviting me.
Hi, how are you? So good to see you.
Thank you. And so thank you again for joining in on the conversation. We've been talking about detection and prevention. And one of the things in your in your responses, Dr. Spencer, is you mentioned men as well as women. And we want to make sure that our men know that there are some preventative measures that they could take. Is there anything different that men should look for? Or what should they look for?
Yeah, the bottom line is if they see something, say something. And
Mhm.
oftentimes, the patients that I've seen, first of all, we see men diagnosed with breast cancer about 1% of the total new diagnosis. And we think that that's probably underreported. But the main thing is, again, if you see something, say something. If there's a lump along the chest, if there's nipple discharge, nipple inversion, if there's a lump underneath the arm. I recently saw a young man that was helping his daughter move into college, and he had some boxes, and he had bumped his chest and noticed the lump, but he thought that the lump was from the trauma, but the trauma just caused the attention to the chest wall. And so he reluctantly went in to get a mammogram and ultimately an ultrasound and a biopsy, and he was found to have breast cancer. But I share that story just to say that with our men, don't talk yourself out of, okay, I'm not a woman, this can't be breast cancer, it's just trauma. If there's something different, even if it's asymmetry, meaning one side looks larger than the other, make sure you go see your primary care healthcare provider right away.
Thank you. Thank you. That is so important. And one of the things that we're told when it comes to screening is that we should go every year. Would you please explain why going annually is important?
Sure. Well, most of our guidelines are put forth by organizations. So you have the American Society of Clinical Oncology, you have the American Society of Breast Surgeons. A lot of the organizations, we get together and try to come up with guidelines that are appropriate for population-based medicine. And so what we're finding is that annual mammogram is appropriate for women over the age of 40 and younger, if they have a family history of breast cancer, to start getting their screening mammograms, because there can be changes from one year to the next. And I'm sure Dr. Phillips Reed has had experiences where the patient may come in and had an annual mammogram last year or even a few months ago and now have a new finding. And so the important thing is, again, ladies, if you see something, say something, even if it's between one mammogram and the next. You may say, hey, I just got a mammogram in December and I feel something in January. This can't be. So we can't talk ourselves out of what could potentially be a problem. We've got to be our own advocate. And if there's something that is different, you go in and you see a healthcare provider right away. Again, screening mammograms once a year, but you may need to get additional imaging in between your next mammogram if you feel something new or if you see something.
Okay. Dr. Phillips Reed, would you like to add to that kind of what happens in between these annual mammograms that for that reason of going annually?
I think if we look at the controversy surrounding mammograms, when you start, how often you should get mammograms. I mean, there's just a lot of controversies. And because of that, there's a lot of mixed information out there, not only to our patients, but also to our primary care physicians and our OBGYN, who are really the gatekeepers of women's health. So I think it's important for each physician who's taking care of women to really and truly understand the controversy around it and decide how he wants to follow his patients. I think it's no question that we feel that it's repeated mammograms. I mean, some women will get mammograms once a year, once, and not repeat it for 4 or 5 years. So it's really and truly getting on a routine schedule where you repeat that mammograms at whatever interval you decide. I mean, the American College of Radiology, they recommend that we do mammograms starting at age 40 and repeat it every year. The American Cancer Society, they have disagree with this. They start at age 50 and they repeat it every other year. If we look at countries outside of the United States, you're talking about, UK, their recommendation is every 3 years. So the most important thing is for people who are the gatekeepers of women's health, they need to decide what they believe and how they want to follow their patients. For me, I feel strongly that once every year gives you the best opportunity to detect breast cancer at an early stage. And also, it's been proven over and over again, if you do it once a year, starting at 40, it really and truly decreased the morbidity and mortality of breast cancer.
Thank you so much. And as we talk about mammograms, let's hear a little bit about access. Can a person schedule a mammogram without a doctor referral?
A routine screening mammogram, anyone can schedule it, but there has to be someone that you want to get that mammogram. So if it's abnormal, you can make sure that it's evaluated. But a person can call up and say, I need this. These are women who are completely asymptomatic. They can call up and say, I need a screening mammogram, and they can schedule their own mammograms. But it's so important for them when they go into the facility, they are going to want to know, who do you want us to send the reports to?
Okay, and so let's what other options if a person does not have medical insurance and they want to get a mammogram, but let's go into they're diagnosed with breast cancer. What are those next steps for them?
There are many options out there if you know about them. One option, women who are uninsured and no insurance, who meet a certain economic status, they can get emergency Medicaid. And emergency Medicaid is a state facility, and it's really throughout, the country. the state will provide, once a diagnosis is made, you can get emergency Medicaid. And again, this depends on your economic status. Obviously, if you're employed, you have a business, or if you have a house, that make it difficult for you, because you really and truly would have to pay, out of pocket. But most hospitals have an indigent program. And that indigent program is for people who do not qualify for state Medicaid and that need services. They will provide services at a discounted rate. I think for routine, screening mammograms, if you do not have insurance, there are organizations like myself that help provide, mammograms free of service. But I think a lot of people do not realize that you can also go to your health department. Your health department will provide mammogram service for you. It's not only for screening, but also for diagnostic mammogram services.
Okay, well, that information is good to know. You, Dr. Spencer, I'm sorry.
Yeah, a lot of the imaging centers will also have a nurse navigator. And so if there's a new diagnosis of breast cancer or a breast concern, the nurse navigator oftentimes will have resources readily available that they can share with the patient based on their county that they live in, because a lot of the ones that are not federally funded but are at the local level are contingent upon the county. And so there are a lot of county-based resources as well. So it's important that patients, if you have a new concern or you have no concern at all, just need a mammogram, to try to go in the county in which you reside, because oftentimes those facilities will have resources that are unique to that area that those women can take advantage of. And I mentioned earlier the Susan Komen Foundation, yes. Sisters by Choice. So there are a lot of organizations that are out there. But to Dr. Rossworth Phillips Reed's point, you have to know to ask for them. You have to be able to be proactive and be your own advocate. We want to think that it would be readily offered, but sometimes it's not. Another thing that's really important is to let patients know that they can ask for the self-pay rate. This is not something that's readily offered, like, do you want to pay self-pay? So the self-pay rate is usually lower than what they would charge someone that had insurance. And sometimes the hospitals may bill you as well, but also ask for the self-pay rate.
That's a good option. Thank you. And we do have a question from our audience. I think this is a good question. Is there an upper age limit on when women should no longer get mammograms? Do we do this the rest of our lives?
I feel strongly, because I see a lot of older women, because they've been told that you reach 74, you don't need a mammogram. And over the past 10 years, there's a significant increase in morbidity or mortality in older women. I mean, you think about it. If you have an older patient and you want to decrease the severity of if you have an advanced cancer, the treatment is going to be severe. As far as doing chemotherapy, you try not to treat the aggressiveness in older patients. And so you really and truly want them to continue to get their mammograms. I have a saying in my office when patients ask me how often should they get their mammograms after a certain age, or whether or not they should be getting them. And I tell them, until you have one foot in the grave, you get your mammograms. The standard answer is that if you have longevity, life expectancy of 10 years, you continue to get the mammograms. My mom is 94 years old. Every year she gets her mammogram. The oldest patient that I have in my practice right now, she's 102. She gets her mammogram every year. Okay. And she's with alert.
It is your recommendation that there is no age limit.
There's no age limit,
Right.
When I think you look at the health of the patient, if you have any disease process that you would treat, that means that the patient, once diagnosed, you would not hesitate in treating the patient. We need to make sure that patient continue to get their mammograms.
Yeah.
Thank you.
And I agree as well. And like she said, it's a lot of controversy, but you just have to let patients know that a lot of the data that bore out in terms of letting women know when they should stop their screening mammograms, the women that were over 70 weren't really enrolled in the trial. So there wasn't a lot of data for women that are over 70 or over 80 or octogenarians. A lot of times they'll do quite well, but they feel like they're excluded from a cure. They're excluded from treatment because of their age, that they can't sustain it. And yes, they may be sometimes a little bit more challenging to treat, but again, the screening mammograms are so important because early detection means better protection at any age.
Thank you. Thank you. So let's talk about diagnosis and treatment. So let's say one is diagnosed with breast cancer. What are the next steps? And it may be look different from person to person, but what's next?
Well, the most important thing is let's just go back to the diagnostic mammogram. When someone gets a diagnosis, if you get a call back, go back. That's important because we see a lot of disparities in people of color, because oftentimes we have opportunities to impact the disease by going forward with the entire treatment. But a lot of our patients may not have a team assembled. They may not have access to a care team. So that's why it's so important. I think Dr. Phillips-Reed mentioned this earlier, that if you get a mammogram, make sure they have a physician of record, whether it's your primary care or your GYN, because someone needs to be accountable and responsible for referring you to the appropriate doctors to start your treatment plan, to formulate a treatment plan. And so oftentimes the patients will meet with the surgeon who will come up with the options to remove the cancer. They also will oftentimes meet with the medical oncologist that may decide if there's any sort of systemic or oral therapy by mouth that they may need, and the radiation oncologist, and sometimes a plastic surgeon if reconstruction is right. So the first step is just having a conversation about the diagnosis, the type of cancer, if there are any clinical trials that the woman will qualify or man will qualify for. And then oftentimes the surgeon that did the biopsy, or if a radiologist did it, you'll have that team assembled and they'll make sure that the patient goes down that path. But that's the most important thing, to make sure that you don't get lost in follow-up, and that if you're diagnosed, ladies that are watching and men, to make sure you get in contact with the nurse navigator at the imaging center as well, because they oftentimes will help put all these pieces together and put the patient back in the driver's seat and make sure that they're not lost to follow-up in terms of initiating and following through with their treatment.
And so what are your thoughts about getting a second opinion? Should a person request it every time?
I think the patient should do whatever they need to get information to move forward. Once a diagnosis is made, a patient should understand the type of cancer that they have, the stage of cancer that they have, and a treatment plan. And once that treatment plan is outlined for them, they either accept the treatment plan, or if they have questions about the treatment plan, that's when a second opinion comes into focus. The other thing is that sometimes there are cancers that are very, very aggressive or unusual type cancers, and patients need to get additional information. They need to seek out multiple specialists to try and figure out how they're going to move forward. But the most important thing is getting the information that they need to move forward. And if you need a second opinion, go forward. Sometimes people need a third opinion, but at that point, when they start going from doctor to doctor to doctor, then you need to really and truly sit down with that patient and say, what's the problem here? And you'll find out the most problem when patients are getting multiple opinions. They really and truly are confused, number one, and they may not want to move forward at all. We have patients who decide that they don't want to be treated, and that's unfortunate. But again, I encourage second opinions. I put it on the table early, and also assist patients when they need my assistance in selecting, places that they need to go for a second opinion. I have no problems with second opinion.
And you both mentioned the physician of record, and Dr. Spencer, you mentioned radiologist. Who are the doctors that need to be involved in this treatment plan? What types of?
Yeah, the surgeon that will be doing the operation, and oftentimes that surgeon will collaborate with the plastic surgeon if there's reconstruction that will be done. Also the radiation oncologist who might give radiation, and then lastly the medical oncologist that will have a discussion about any systemic or therapy by mouth. And I do want to add another thing about second opinions. A lot of
Okay.
times patients come for a second opinion. It's not that they want to be told something any differently, but they just need more clarity. And it's difficult sometimes to add clarity with competency and compassion. So you want to make sure that you are gelling, that it's a good fit, because the journey is too important to feel antagonized or feel like you are not seen in your during your visit, because oftentimes the patient will just shut off and not want treatment, not always specifically because they don't agree with the treatment plan, but they're not gelling well with the team. And so it's so important also that they realize that if the bedside manner isn't there, if it's not a good fit, that you seek a second opinion so that you can feel comfortable. Because I find that the more comfortable patients are and the more clarity that they have and the more compassion that they're given, oftentimes they feel more confident in moving forward with the treatment. And so it's important to also consider that too.
Yeah, I definitely understand that. We're told to have an intimate relationship with our doctor. And when you have that, I feel like you're more comfortable with asking those questions too. So I certainly get that. So let's
think
go
also
into,
we
go
should
ahead, Dr. Phillips-Reed.
Yeah, we should realize that this is not a short-term relationship. This is a long-term relationship. Most of our patients need to be followed for the rest of their lives. It doesn't mean that they're going to have breast cancer for the rest of their lives. But once you have breast cancer, you are at risk for developing a second and a third breast cancer. And you really and truly need to be followed forever. And so I try and emphasize to the patients the need for continued follow-up. That is almost as important as being treated initially. You know, I've had multiple instances or more times than not where a patient is treated for breast cancer and they are cured, and then they drop off the place of the map. You don't see them, and then they pop up 10 years later, and you've cured one breast cancer, but then they pop up and they have an advanced cancer. And I can't understand that. I mean, you successfully was treated for one cancer, and yet you did not continue your follow-up. I emphasize to patients, once you've had one breast cancer, your risk as you get older, your risk for developing a second cancer increases, and you need to have that long-term follow-up. So being comfortable with your doctors, and it's usually not just one doctor. Most patients are followed not only by the oncologist forever, but also by their surgeons. Very rarely the radiation oncologist follow them forever, but they do follow them for 2 to 5 years. So again, this is a long-term relationship, and you need to be able to connect and relate and feel comfortable with your doctors.
So let me expound upon that just a little bit. If you've been diagnosed with breast cancer, you've been treated and you're cured, and how does your follow-up look different from someone who's not been diagnosed with breast cancer but still going through those preventative measures such as the mammograms and self-checks? How does their follow-up look different? What does that look like?
Usually they follow up annually. If someone doesn't have a history of breast cancer, they do an annual clinical breast exam and have their annual mammogram, screening mammogram. And I follow the American Society of Clinical Oncology guidelines, where you see the patient every 6 months for 5 years. But the mammogram is annual, but the clinical breast exam is every 6 months for my practice for 5 years.
Okay, thank you. Thank you. And so let's go into surgery. Both of you are surgeons, and I understand that there are various different options that a patient can take when it comes to having a mastectomy or not having a mastectomy. I understand now that that doesn't necessarily have to happen. Would you both share a little bit about the surgical options and when that stage comes for a breast cancer patient?
The options patient have is directly related to the stage of their cancer.
Okay.
Early breast cancer have many different options. You can do a lumpectomy, which means going in and removing the cancer. If you do lumpectomy, most often, 99.9%, it does require some type of radiation. If I have a patient that does not want radiation, then they're limiting their option as to, if you don't want radiation, your option is very limited. The other option is mastectomy with and without reconstruction. And reconstruction today is really and truly is the best it has ever been. But I always tell my patients that we are not going to be able to make you look exactly the way God made you. It's just, there will be some difference in the overall cosmesis. But in general, your options are lumpectomy, mastectomy with and without radiation. For our older patients, we are realizing that they can be treated with radiation, with medication. If they have a very small, tiny lump, they can do lumpectomy without radiation. Or if we feel that they are prohibited as far as surgery is concerned, we will just put them on a pill and follow them.
Okay. I know that Dr. Spencer is going to leave us momentarily. So I want to ask Dr. Spencer, and I'm going to come back to you, Dr. Phillips-Reed, to talk about the types of breast cancer. But Dr. Spencer, before you have to go, please share with us a message that you want the audience to know that's most important about breast health.
Oh, sure. I mentioned at the very beginning, and that is early detection means better protection. So again, in terms of the ABCs, the A is awareness. Just be aware of your body. If you see something, say something. Be aware of the guidelines. You get your annual screening mammogram starting at the age of 40. Be aware of your family history. The B is behavior, exercise. Try to maintain a healthy lifestyle in terms of what you're eating. C is your consumer choices. Be mindful of what you're putting in your bodies and on your bodies. Now, one of the things I did not mention, and I would be remiss if I did not, in terms of treatment, a lot of women are apprehensive to have the surgery that Dr. Reed-Phillips just mentioned, the chemotherapy, the radiation, and oftentimes they will decide to treat themselves. They will treat themselves with vitamins and supplements and IV infusions at facilities or on their own. And I have, in my practice, and Dr. Phillips-Reed, you can weigh in on this, I have seen the most problematic and most aggressive progression of disease when patients try to move forward with their own treatment plan. And so we want to make sure that the patients are sharing with their doctors and their care team what they're taking. But we have not seen that when you exclude surgery, chemo, and radiation and just do vitamins alone, that we've seen the same cure rate and the same low recurrence rate as we do with your traditional surgery, chemotherapy, and radiation. And again, it can be complementary. We can add your vitamin supplement, but we still need to know what you're taking, because some vitamins and supplements can interact or even reduce the efficacy or how well a medication may work. So I want to just encourage the women that are watching that if you are considering a treatment plan that does not include surgery, chemotherapy, radiation, that you're increasing your risk for recurrence, you're increasing your risk for the disease spreading and metastasizing and even death. We just don't talk enough about that in the medical community. A lot of women may be ashamed or embarrassed to let their clinicians know, I don't want treatment, but I am treating myself, just not at the hospital. And those patients will inevitably come back that have refused surgery, chemo, and radiation with the disease is so advanced that they're no longer a surgical candidate. They're no longer a candidate for radiation or chemotherapy. So that's just important that I really wanted to make sure I mentioned that, be very clear about that.
I'd like to also add, when we talk about treatment with breast cancer, we have to emphasize that your cure rate is directly related to your initial treatment. Mm-hmm. African American community, we have a lot of delayed in diagnosis and delayed in treatment. And when you delay your treatment, what will be offered for you, say, 6 months initially, If you wait 6 months, it may not be that same thing, and your cure rate is directly related to your initial treatment. When cancer comes back, we no longer talk about curing you. When you present to us, we try and give you the best plan to make sure that we have an opportunity to cure you. When cancer comes back, when breast cancer comes back, we no longer talk about curing you. We talk about controlling the disease. And that's like night and day. Cure versus controlling the disease. Patients who present with recurrent disease have a high risk of dying of their disease. So when you delay treatment or refuse treatment, you really and truly not giving yourself a chance to be cured.
Thank you. Thank you so much. Thank you, Dr. Spencer. We appreciate having you.
Oh, thanks
Thank
for
you.
having me.
And Dr. Phillips-Reid, you talk about treatment, and sometimes I've heard people say they're doing an aggressive treatment. And that makes me think about the different types of breast cancer. Does that relate to different types of breast cancer? And can you talk about what are the different types of breast cancer? I know we've heard a lot about the triple negative, but I understand there's a positive also. So
right, there are many types of cancers, and we have heard a lot about triple negative breast cancer. And initially, when we started recognizing, triple negative breast cancer, we put a very negative tone to it. We gave women ideas that if you were diagnosed with triple negative breast cancer, you were going to die of triple negative breast cancer. And I can remember a conference that I had for community people and community leaders and patients, where one of the physicians, and it was a belief at that time that triple negative cancer was so aggressive that if you got it, your chances of surviving was, extremely, extremely low, and the chance of dying is high. So what happened in that moment, this lady, and it was a patient of mine who has subsequently had not only been diagnosed at that time with the triple negative breast cancer, she has had her second triple negative breast cancer, and she is a 20-year breast cancer survivor from one and a 15-year from another. So we are treating all cancers much, much better than we have ever treated it before. People are surviving, and they're surviving because of new treatment that's been discovered, new medication. We are, and people that we sometimes used to think we had to be aggressive, particularly in a lot of the ER/PR positive cancers, we no longer give those women chemotherapy. So way back when, if you think about where we came from, and in order to really appreciate where we are now, we came from a time that once a woman was diagnosed with breast cancer, the treatment was the same. Every woman got a mastectomy, chemotherapy, and radiation treatment. That was what everyone got. So you fast forward 2, 3, 4, 5 decades, ahead. We try not to be overly aggressive or overly treating patients, and we look at the biology of cancer cells. So all breast cancer cells are not aggressive, and they don't need chemotherapy. They can be treated with anti-estrogen medicine. On the other hand, there are some cancers that are really aggressive, particularly what we see in young women. Triple negative breast cancer in young women tend to be, more aggressive than triple negative breast cancer in older women. We are very aggressive in treating young women. We have a HER2 positive cancer. That's a gene that's the cancer cell, produce that causes the cancer to be very aggressive, and we are aggressive in treating them. And we have a cancer that's lobular carcinoma that sometimes is we call it, it's kind of the hide and seek. Sometimes it is very, very mild and we easily can control it. And other times, it's almost like it changed colors on us. So there's many different types of cancer that we treat. When we sit and when I sit and listen to some of my patients talking to each other, they'll kind of say, trade war stories about what they've gone through. And they'll say, one of them say, well, I had this one and I had this. And they say, well, I didn't have that. That means that does not necessarily mean that you did not get the treatment that you wanted. It just means that your cancer did not dictate, the same type of cancer. So again, there are just many different types of cancer. Overall, no matter how aggressive your cancer is, the key thing is the stage of diagnosis. Okay. Early cancer is easier to take care of than later stage cancer. So again, when we look at African American community, more women die of this disease because we present late. Late stage breast cancer is very difficult to treat. That doesn't mean that we don't have some successes. We have a lot of successes, and we're continually to change, how we treat cancers to provide better overall outcome from these aggressive cancers.
So you said a great deal there, and I understand what you're saying. And something that stood out to me is that treatments have improved over the years, and you've been in your profession as a surgeon and working with patients for many years. Is that gap closing? I mean, and what I mean is when you look at the rate at which Black women get breast cancer, from what I understand, at the same rate as white women, but Black women are more likely to die. Are those numbers lessening? Is that gap closing?
Those numbers are closing, but there is still something that we do not understand about why Black women continue to die at a higher rate of this disease. All right. But we do understand how important the stage of the disease is. It's important. Also, the type of cancer. Black women seem to have more, triple negative breast cancer. And also younger women, both young Black women and young white women have more triple negative breast cancer. But again, when we look at Black women, we are dying more from this disease. And we talk about the successes that we've had with treating breast cancer. We as African American women are not benefiting as much from the successes, the nuances of how we're treating breast cancer as our white counterpart.
And I would like for you to expound upon that, because we have been advocating and educating, and I've seen that grow and change over the years. In your opinion, and your expert opinion, what could be done differently to help close that gap?
One of the things, it's interesting because I was talking with a colleague from University of Arkansas as I was driving here, and we were talking about African American presenting with later stage diagnosis. I think education is so important for women to understand, about breast cancer and decrease the fear about being treated. I think we as a society, meaning African American society, we embrace alternative treatment more so than any other culture. All right. I have no problems with people, embracing, herbs or vitamins. I don't use the term alternative. I think alternative, and I have no problems in saying this, alternative medicine alone kills. No question in my mind. I've seen it so many times, and it is really, really heartbreaking to see someone die of untreated breast cancer. I like to use the term complementary. And complementary medicine embraces everything. It embraces our standard, care, the treatment that has been proven from clinical trials, our religious belief, I believe in the power of prayer, and all of the, exercises and all of the things that we do to increase our immune system. But I do not like using the term alternative medicine. Complementary medicine is what we need to be embracing. And again, we as a culture, we embrace alternative treatment plans more so than any other culture. And that is what's killing so many. Yeah, and when you sit and talk, I mean, I can tell you so many stories of I'm sitting and talking to a young woman who comes in with a huge, nasty, draining breast cancer and trying to get them treated. And they'll listen to me for a while and you think you have it, and then they'll go home and they'll call you and say, I'll call you, when I want to be treated. Or, which more importantly, I have patients who will use alternative treatment plan. Remember, these are not covered by your insurance. And then when they run out of money, then they come to you and they have a huge, cancer that could have been treated earlier. So you can't pay for your and these are women sometimes who have insurance. So again, I think the fear we need to try and diffuse and try and keep, in touch with these women who decide they do not want to be treated, or a man who decide, some women, and these, men sometimes are the reason why women are not treated. Some husbands, some significant others, they do not want their wives treated. They do not want them to do chemotherapy. They do not want them to do a mastectomy. And those women, because of the love and the respect that they have for their person in their lives, they choose not to be treated. So there's all kinds of reasons that women in the African American community are not getting the same outcome. You have to do the same thing. And that's what we have to do consistently, get women in our community to do the same treatment. I believe strongly if we're able to do the same treatment, you get the same outcome.
So that's really good information to know, and very informative. And so I definitely hope that our audience understands better now related to treatment and not fearing treatment. One more question before we close out. I do want to ask, going back to the triple negative, I read and you mentioned younger women, but I also read in women, younger women who are considered young, but what would be considered past childbearing years. And I read where the triple negative is higher for women who've not had children. Is there a connection there? And if so, why is that? And what could be done differently? I mean, I know we talked about, eating properly and things like that.
Yeah, I think when we look at the overall, type of cancer that we get, I don't think it's really embedded in your DNA, or I really and truly think that is something I don't think we can control. All right. I think we look at African American. I'm sorry, somebody's holding my camera here and not doing a very good job.
I was wondering where you went, but it's okay. Thank you.
We can look at the age of menstruation. We have looked at all kinds of things and trying to figure out why it appears in the African American community that there is a high incidence. We've also looked at the obesity relation between the triple negative cancer. I think we really and truly don't really understand, but we will get to that point and understanding more and more. One of the things that I meant to mention is that we realize that there's just not one type of triple negative breast cancer. There's about 4 or 5 different types of triple negative cancer, and all of them are not very aggressive, and so that's one thing I try and emphasize to my patients is that, although when we say triple negative breast cancer, that does equate to having chemotherapy, all triple negative cancers are not aggressive. And there are some types of triple negative cancers that are more favorable, than even the ER positive cancer with a better overall prognosis. So again, all triple negative breast cancers are not, bad. 100% all triple negative cancers that we see right now dictates chemotherapy.
Okay. So I do have one more questions that I would like to take from the audience, and then we can wrap up. And that is, would you please comment on when and how the newly advertised metastatic, I'm pronouncing that correct, metastatic breast cancer drugs are utilized, when and how they're utilized?
These when you have metastatic breast cancer, usually today it is when the cancer has come back. There is a small percentage of patients will present with metastatic breast cancer. We always use first line treatment and second line treatment drugs before we go to a lot of the immunotherapy drugs. We use the immunotherapy drugs most often when depending on the DNA of your cancer cells. So everybody who has metastatic disease does not necessarily qualify for the immunotherapy. I think immunotherapy is the nuance of all cancer, where we are giving you drugs to increase your immune system to fight the cancer. We have had a great deal of success in breast. We've had a great deal of success in also prostate cancer. And I think it's going to continue to be the nuanced new thing that we utilize going forward. And soon will be a frontline drug, but we're using it mostly in metastatic cancers. Again, you have first line, second line drug that we use that are standard of care. But once a cancer comes back, we utilize a lot of the immunotherapy drugs, and particularly, I am impressed with patients who have ER positive tumors. We have a whole host of drugs that we use for the for recurrency in the ER positive cancers. We have many options for them.
Well, thank you so much. And so this has been very informative, very enlightening, and we certainly appreciate your expertise and for joining us again this year for this important conversation. And so on behalf of the Camellia Rose chapter of the Links Incorporated, thank you very much, Dr. Phillips-Reed.
Thank you, guys. And I really and truly appreciate what you guys are doing. I mean, organizations like yourself should really and truly help, increase education about breast cancer. And we as, breast specialists, we really and truly appreciate what you're doing.
Thank you so much. And we definitely appreciate what you're doing too. So thanks for always being available to us.
All right. Thank you. Good night.
Good night.